Really appreciate you joining today. Here's the title of this workshop, Building Bridges Between Harm Reduction and Treatment for People with Substance Use Disorders. So this is a two-part workshop. So, today's session is going to focus a little bit kind of more on background, and then next week get into kind of some case studies of examples where, sort of bridging these two areas will happen. So just as a disclaimer, this is, supported with support from SAMHSA, but the contents are the responsibility of the Northeastern Caribbean Addiction Technology Transfer Center and specifically me. So just want to reiterate, I'm sure many of you have heard this before, really trying to emphasize people first language. Everybody kind of comes to this topic with different feelings and kind of different terminology they use. So just ask, to kind of respect that, there can be different views and different terms people use, and, feel free to comment in the chat. I kind of point out that I tend to sometimes switch between substance use disorder and addiction, specifically focusing on that end of the spectrum, and talk about recovery really broadly. So just the same way that people recover from natural disasters or an accident, illness, that kind of thinking about recovery really expansively and not tied to any certain path. So just a little bit about my background. I started out my career mostly in journalism and taught media ethics for many years. I went back to school to study public health just before the pandemic, really motivated by work that my husband and I had been doing. He's a photographer and is someone who decided to be open about his trajectory through addiction, the criminal justice system, incarceration, and then now coming up on 13 years of recovery. So we had been working on projects, and I felt like I wanted to get a little bit more background in kind of research methodology. And so I enrolled in a public health program in 2017. So Graham and I still collaborate on a lot of projects. This is, we like to try to bring kind of this topic into art as a way to do community engagement. So we curated an exhibition called Beyond Addiction, Reframing Recovery that has projects, about a dozen projects that really range from, photos from harm reduction in New York City, decades ago, to, support for recovery, and, mostly working with artists and students who have some personal experience with this topic. And then on the right, we, created a banner. This was for an exhibition in New York City during the pandemic. We had been visiting a lot of service providers in about 4 different states, to document the work of groups that receive support to do mostly reducing overdose deaths. So, kind of expanded into, working with public art. So you can see a bit more on my website, but more recently I've been kind of moving into doing more training. So this is a topic that I pitched, really having found that, this, as many of you I'm sure realize, had been, there can be sort of silos. So really, to me, I'm sort of interested in what I kind of call the connective tissue and, continuum of care and how these things can be bridged. So that's sort of, using sort of bridges as a metaphor here. You could do a whole separate workshop on bridging treatment and recovery support, but really focusing on kind of understanding harm reduction more broadly and, discussing that in different definitions, and then how that can be connected in different venues to treatment for people with substance use disorders. So these are just sort of the learning objectives, really kind of talk about harm reduction principles, practices, and impact, and then kind of discussing concerns about harm reduction and treatment for substance use disorders today. And then next week, we'll kind of move into these case studies I talked about, kind of how can these connections be strengthened, and examine how treatment providers are increasingly incorporating kind of harm reduction approach into their work. So this is just a poll. I don't know if it'll pop up as a poll, but just to kind of get a sense of, how familiar you are with the concept of harm reduction. So, number 1 would be very familiar, kind of you could explain what it means. Somewhat familiar. Number 2, heard of it, but not sure that you'd, define it on the spot. And then not too familiar. So you can just kind of add in the chat, lots of ones so far. So you can just add 1, 2, or 3. Okay, great. Looks like there's a lot of ones here. So a lot of ones, but, just to kind of start with, a broad overview. So this is thinking about harm reduction, outside of the context of substance use. So, you can think about it as a set of practical strategies aimed at reducing the negative consequences associated with risky behavior, aims to give people the information and resources they need to make safer choices, and really kind of enables people to take steps towards living a healthier lifestyle. So these are just examples of, harm reduction in many areas of our lives, whether it's bike helmets, sunscreen, seat belts, condoms, these are all ways to kind of help people understand harm reduction in kind of a wider context of, practices to reduce risk. So since there are a lot of ones, curious to see how you would describe harm reduction to someone who asked what it means. So, feel free to raise your hand or post in the chat, kind of thinking about the fact that there isn't just one definition, so if you feel more comfortable speaking, otherwise feel free to post in the chat, how would you describe harm reduction if, you were out and someone said, well, what does that mean? I've not heard of that. So Iman writes, meeting the client where they're at, non-judgmental approach and not imposing my personal philosophies or beliefs onto the client, acceptance. So that hits a lot of points. Shariah, please correct me if I'm mispronouncing your name. Harm reduction to me is loving people who use drugs, help client explore strategies to reduce use, saving lives, a more common sense-based way, humane way of working with people anywhere on the spectrum of substance use, interventions focused on reducing harm associated with use. Feel free if you want to just speak too, if you want to raise your hand or just unmute.
Okay, hi, good morning, everyone. Hi, Susan. So based on, previous knowledge, it will be any approach to providing any sort of information to a person who might be, going through some difficulties around addiction or any other things, like risky behavior could, be different things. Okay, sexually speaking, reckless driving. So just providing information about how this person could, minimize any possible, negative effects based on his or her behavior.
Great, thank you. And I'm kind of toggling through different screens. So when you speak, if you could just introduce your first name too, so we can tell. Sorry, I missed that there. But yeah, that's a great summary of it. So, really, you can look at it as a philosophy, a strategy, and I'm going to show a few definitions just to kind of show that there can be different ways of approaching this kind of as a topic. So, just to capture some of the principles, many of these you've mentioned, this idea of kind of respectful, non-judgmental interactions, is a really core principle, thinking about, the history of substance use and treatment, that, that can be something a lot of people experience, and it can be, dissuade people from seeking care, empowers people. I think that's really important to kind of, that this is thinking about a strengths-based approach, to reduce harmful behavior by providing tools that they can use. Supports participants' goals. Sometimes that's something that, historically has not been a core focus of treatment, but really thinking about, what is the participant looking to do at this time, and that can change over time. Recognizing that abstinence from all substance use may or may not be a goal. Again, that's something that can change too. And really prioritizing holistic person-centered care. Now, these are all ideals. Anybody working in this field kind of knows that, they're not always achieved, but, these are kind of core principles there. So just also wanted to share a few different definitions just to illustrate that, there can be different ways of describing this. So these are from the National Harm Reduction Coalition. And, starts off with, they have a lot more information on the website, and everyone will get copies of these slides, that contain links. But starting out as describing it as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Also a movement for social justice built on a belief in and respect for the rights of people who use drugs. So interestingly, they really point out there's no universal definition. So that's why, people can describe it differently. Some of your definitions highlight different things. But they also point out on their website sort of the difference between this, harm reduction lowercase there and harm reduction uppercase, which, I hadn't really seen before, but that uppercase is sort of a, referencing the movement for social justice versus the lowercase, the strategies, whether that's something that kind of is clear to people highlighting, but, just interesting to think about that these might be sort of separate ways of thinking about harm reduction in different contexts. And, also noticing here that the emphasis is on drugs specifically, people who use drugs as opposed to kind of more broadly, other substance use or other risky behaviors. So here, harm reduction at SAMHSA, this is, you'll see sort of a much more detailed, and again, Harm Reduction Coalition does have more information on their sites, but really, again, it talks about emphasizing engaging directly with people who use drugs to prevent overdose and infectious disease transmission, improve the physical, mental, and social well-being of those served, and offer low threshold options for accessing substance use disorder treatment and other health services. Harm reduction is an important part of the Biden-Harris administration's comprehensive approach to address substance use disorders through prevention, treatment, and recovery, where individuals who use substances set their own goals. So here you can kind of see that, this is a broader definition that kind of puts in a lot of different, both strategies and goals, as well as, embraces kind of prevention, treatment, and recovery within this broad spectrum of harm reduction. Any thoughts on these different definitions or comments or descriptions? Feel free to raise your hand or post in the chat, anything.
I think what's missing that's really, really important in harm reduction is that it's people-centered, that the person we're supporting is defining what that looks like.
Okay. Yeah, so I think probably if you went to some of the web pages here, there'd be more information, but it is interesting to kind of point out that, particularly kind of coming from this perspective, the one I have up here, that, here we kind of have set their own goals. So thinking about it that way, but, really this person-centered, what is an individual need and kind of what is the range of complex behaviors that they're trying to address in that moment. So, thank you for adding that there.
And the fact that this second statement is focused on prevention, treatment, and recovery, where we will allow them to set their own goals, but if they're not preventing or seeking treatment or in recovery, and their goal is simply to reduce X behavior, Y behavior, stop a different behavior, but to continue use, they're not included in that kind of addressing substance use disorders through prevention. To me, it should read through prevention, harm reduction, treatment, and recovery.
Yeah, I think that's an interesting oversight. I mean, there is a long history, and this is something I know Jason is on this, participating in this workshop, has written about, of discussing and talking about harm reduction. In the sentence section here, it's sort of, that's describing it as the government's strategy, through prevention, treatment, and recovery. So I think in other places you'd probably find, more references to harm reduction. That's certainly a newer thing that the federal government at least is embracing, and, certainly hasn't flowed down to, every locality, but, that's something that could be added here. Although in other contexts, I have seen harm reduction included in kind of, strategy documents. Carol's adding, I think in the chat, I think far too many people look at harm reduction as a temporary stopgap on the way to abstinence. Ashley asks, can you comment on how harm reduction can work its way into courts and treatment courts? Historically, courts expect abstinence and don't allow for time for harm reduction. It's seen as a risk to the public, risk to commit new crimes, or risk for the safety of children. I'm currently working in family treatment court. So we're going to probably get into some of those case studies next week, but that's a great example of places where a harm reduction approach hasn't necessarily filtered down, or might be seen a little bit differently, in different places.
I think also we can look at industries or companies that do drug testing. Is another area where harm reduction is just not even considered.
Yeah, and there is an example that I'll be talking about next week of sort of more of a harm reduction approach to drug testing. So thank you for mentioning that, Carol. So this is a definition, from the project that ended up on the banner, that I thought, when we were discussing, or talking to people both who provide services and receive services, for a really wide range of organizations in several states. This is someone who grew up with two parents with substance use disorders, one who died from an overdose and one who is in long-term recovery. And what she described really struck me. So, I've shared it in different venues, and JV says, I think about harm reduction from the point of view of the kids helping their parents and how we can reduce harm all around. If we're thinking about healing and supporting folks, harm reduction means creating safe spaces that don't make them feel isolated or ashamed, a place where it's not on the kids, the parents can get help and not be judged. Because the minute you shame them, someone else has to pick up that ball you dropped when you could have showed compassion, and it's usually the kids or family members that still come around. So, this really is something that, sometimes when we think about harm reduction and certainly public health goals within harm reduction, there can be an emphasis on kind of certain harms, but not necessarily other harms. And I think putting this in the context of, harms to children and how if someone isn't receiving services or feels isolated or not, accepted at services, that does put the responsibility sometimes on, not just children, but other family members and friends to kind of, be that support system, but also then experience the harms of someone not getting the care and services. So, this is just a different perspective. So I think, you could do a whole collection on how people describe harm reduction. And, Carol is writing here, we don't really define harm beyond the public health sphere, not the emotional impact on others, the risk of incarceration or institutionalization, where harm reduction strategies are far more difficult to practice. And as someone who kind of lived through both, the effects of someone's addiction as well as incarceration and, the lasting impact of a criminal record, I definitely, the experience of family members and also the impact on the community is something that really resonates with me. Any other thoughts sharing about this, or just kind of that broader question of, what harms are we focusing on with some of these strategies and interventions? And are there any harms that get left behind with some services?
For me, the incarceration institutionalization is really important. People do get infected with HEP or HIV while incarcerated because it's impossible to get access to clean, sterile equipment. People have to share drugs however they can. And some of the alternatives that people self-produce while incarcerated cause a lot of harm.
Mm-hmm.
And so in preventing arrest, that to me is really a key factor in harm reduction.
Mm-hmm. And that's one of the examples I'll be talking about next week, is kind of this idea of, deflecting people from the criminal justice system. But that's absolutely correct that, a lot of harm reduction, that happens outside carceral settings is not necessarily happening inside. There are examples of, naloxone education or distribution, before release, that happens in some places, not others. And then kind of other approaches within jails and prisons, but definitely, if you're looking at sort of institutions where harm reduction as an approach hasn't really necessarily filtered into the same degree, that would be a place. Any other thoughts about, kind of when we're thinking about harm reduction, what gets included and what achieved by certain strategies, but maybe not others?
I don't want to monopolize, but also the whole issue of driving drug use underground so that people are removed from social service access that could support some of the issues underlying the substance use, and the fact that we focus on substance use as the problem rather than a symptom.
Yeah, so thinking about, when people aren't welcomed into services or don't feel that services meet their needs, sort of what other problems does that create, if I'm kind of encapsulating what you're shared, can be sort of the spectrum of harm. So, kind of thinking broadly about examples of harm reduction, what are some examples of harm reduction related to substance use you've heard about or used? And this is just kind of meant to be a sense of, feel free to add into, syringe access, overdose prevention sites, syringe exchange, feel free to just put anything in the chat, kind of trying to get a sense of what comes up when you're asked that question. Fentanyl test strips, naloxone, safer use kits. What about thinking kind of more broadly? Condoms, motivational interviewing, risk assessment, agonist therapies, so medications, testing for HIV and hepatitis C, MAT, partial abstinence, access to care, drug use diaries, curious to hear more about that, acupuncture, overdose response teams. I was able to kind of go out with a team in Southern Ohio. That was really interesting to see. So, some models of that in different places. Medicaid expansion and covering MAT within the last 2 years, broke down big barriers, a trauma-informed approach, providing food showers, clean clothes. I think that's something a lot of people don't necessarily associate, particularly with syringe service programs. We're going to talk about that. Training around wound treatment, especially with xylazine now, that's becoming a service that a lot more organizations are focusing on. Access to medical supplies and medical care. Yeah, so these are, overdose response kits, definitely. So naloxone. Never use alone hotline. Peer support services, great. Alternative activities. I'm gonna change my screen a little bit here. I've taught college and I started hearing from a lot of students that they're visual learners, and I live with a photographer, so I like to kind of incorporate some visuals. So just thinking just about, sometimes tobacco gets overlooked in these settings, as when we talk about harm reduction, but just some examples from alcohol and nicotine, whether it's dry January, low or no alcohol drinks, designating a driver, nicotine gum or patches, these are all, examples of, harm reduction in the context of substance use, tobacco specifically and alcohol. These are many of the ones you've mentioned, certainly carrying naloxone and learning how to use it, new syringes and supplies, fentanyl test strips, and then, this never use alone hotline. Curious how many of you, if you just want to post in the chat, have heard of the never use alone hotline? you know, a resource. I should add that you can also text. Is that something you've heard of before? Some yes, some no. Lots of yes. Okay. So yeah, these will be in the slides, and I'm just noticing that I should kind of add the website for that. So I will do that. Great. Brianna writes, I give it to all my consumers I come in contact with. It works, you know. So, you know, when in one of the organizations I was working with, you know, it was discussed that, you know, sometimes people prefer to use alone, you know, sometimes women, and that this is a resource for people who, you know, maybe have that preference or don't have another option to call someone. And then that person, you know, this is staffed where they will, through volunteers largely, they will kind of monitor someone as they're using and then call for help if there's any problems. So, you know, I think traditionally these are organizations, you know, when people think about harm reduction, syringe service programs are kind of the primary venue where harm reduction has thought to be kind of happening. So just based on kind of what everybody's shared so far, I think a lot of people are familiar with these, you know, community-based organizations that provide sterile syringes and other supplies to people who use drugs. Many also distribute the overdose reversal medication naloxone, test participants for HIV and hepatitis C and help them get treatment, offer food, clothing, showers, and mail services, serve as drop-in centers with respite options, peer support and counseling, provide or connect participants to treatment for substance use disorders and medical care, and sometimes offer mobile services too. I'm kind of monitoring the chat here too. So I had the opportunity to visit, you know, a number of syringe service providers in different parts, in different states for this project. Here's one. This is actually from Flint, Michigan. And, you know, saw some, you know, got to see a lot of this work, and it really expanded my understanding of what's being provided. And there can be real variations, you know, depending on the resources available, how long these organizations have been around. But, you know, one of the things that we were trying to highlight, you know, in documenting the work of this places were, you know, some of the things that people don't hear about, you know, that it might be providing mail services, you know, as, you know, I'm going to talk about a place that does that next week. But, you know, thinking about a broader, you know, some of this was mentioned in the chat, you know, food, clothing, showers, and mail. I come out of a media background, so pay a lot of attention to how things get represented in the media, and sometimes, you know, showing syringes over and over as sort of the primary visual associated with SSPs can kind of reinforce that in the public, and that, you know, these other, you know, services that are provided don't necessarily get as much attention. I'm seeing in the chat, I'm just catching up here, someone asked BORG, blackout rage gallon. I don't know, Danielle, if you want to explain that. I might have missed part of that chat, but Marco asks, the testing drugs is the first time I've heard about it. Are there steps to be used with which drugs? Anybody wanna, I can answer that, but does anyone want to share who's kind of worked with testing?
We do a lot at where I am at Lantern Community Services. We're one of the DOH's pilot sites for fentanyl test strip distribution. And considering the fact that pretty much every street drug at this point contains fentanyl, there are steps that can be taken to take a sample from your drug and see if there's fentanyl in it, and then really think about, because most people aren't going to throw it away even if there is fentanyl in it, think about how they're going to use it, like using it in smaller amounts or little by little, and informing somebody that you are going to be using fentanyl and having a Narcan kit nearby.
Thank you. So, you know, that's, I think, I'm going to just go back to this visual here. Whoops. there. So these are the test strips, the green, Marco. So, you know, you asked too, sort of to be used with which drugs. The substance needs to be dissolved in water or liquid to be able to test it. So you can crush part of a pill. You know, if I showed a kind of open version of that, you know, it looks almost like a tiny strip of paper that then will show, you know, detect the presence of fentanyl there. And, you know, for people who use cocaine and increasingly fentanyl is being found in other substances that, you know, people have no idea would be mixed in. So the idea is, you know, to more broadly spread awareness about, you know, the possibility that fentanyl might be in other substances and then make these kits more available. And there was, I noticed just the other day, an article in the Washington Post about more and more states, you know, in some areas, fentanyl test strips are actually, you know, criminalized, but more and more states, the Washington Post was writing about this, have started to decriminalize them and kind of make them more accessible. So this is what can be sort of used to test for that. There are also, you know, some places this is happening more in New York City that have, you know, what are called mass spectrometers. So, you know, the ability to kind of bring drugs to, you know, a location and have the drugs tested. And that can kind of more realistically inform surveillance within the community. So, you know, they're expensive machines, so not necessarily going to be widely available, but that helps places like New York City and kind of some other communities find out, you know, what's in substances, and then there are alert systems to kind of share that information. So increasingly, you know, some organizations are kind of trying to spread the word via social media and other networks. Hey, we've been testing and this is what came up. So, you know, that's kind of how, you know, the fentanyl test strips test for fentanyl, but these machines test for other substances as well. Carol, like a pregnancy test, thank you. I should have accessed that, but you know, it comes up if there's fentanyl with the test strips. Any other questions or comments on that?
I think also what you mentioned in terms of alerts are a real important piece of harm reduction in terms of people empowering people to help each other. And we've used them in places where I've worked, not just around drugs, but around sex work in terms of license plates of people who either don't pay or get violent, things like that.
Yeah, that's a great example. Thank you. As particularly for sex work too, I did get a chance to spend time with an organization in Philadelphia that has an alert system. You know, they're just kind of warning people, you know, about incidents that happen, you know, might be a certain car, a description of an individual, but social media is really, you know, used for these kinds of systems. And increasingly, I think public health departments with respect to, you know, xylazine or other substances that are kind of turning up in the drug supply, you know, are kind of trying to get the word out, you know, not just to people who use drugs, but also kind of emergency services, health officials, and people working in different treatment and harm reduction settings to kind of know what's happening. Anita asked in the chat, are there xylazine test strips? Tamara answers not yet. You know, I think that's something that many communities are increasingly, you know, dealing with, and, you know, that substance is showing up more and more in different communities. So these are, you know, this kind of comes from two sites here, both NIDA and the CDC. You know, sometimes there can be, you know, debates about, you know, what are the benefits of syringe service programs, you know, increasingly, I think, being accepted in different parts of the country, you know, particularly these things, evidence shows that they reduce HIV and hepatitis C infections, you know, through distribution of clean supplies, prevent overdose deaths by providing naloxone training and distribution, reduce syringe litter by offering safe disposal options. So sometimes that's giving kind of smaller sharps disposal kits to participants to take away. You know, some syringe programs operate on an exchange, so, you know, you bring some back. There was a model in New Haven that I saw where they actually had a small grant to pay people for when they brought back syringes. So, you know, many SSPs and other organizations organize, you know, cleanups, you know, participants and staff members kind of go out into the neighborhood and kind of try to pick up and really encourage each other to kind of be respectful of the community. Many, you know, connect participants to HIV, hepatitis C, and substance use disorder treatment as well as other health services. And generally evidence is found that they don't increase drug use or crime in the community. Again, sometimes, you know, this kind of media coverage or, you know, increasingly now social media can really be a vector for kind of, you know, if something does happen, then, you know, there are examples of where something, you know, whether there's a protest about a service already operating or efforts to not, you know, allow services to open. This kind of data point is something that gets focused on. And this is a map I just kind of came across. I'm curious if others have found it. I mean, this is something published by the health website Kaiser Family Foundation, illustrating syringe service programs around the US. So I noticed some commentary about the, you know, some of these numbers are, you know, older, so don't actually correspond. But if you see sort of the lighter blue here, there's a number of programs in each state, you know, so as it gets darker, increasing, you know, number of syringe service programs. So, you know, I was looking for estimates, you know, to kind of try to capture how accessible these programs are and, you know, numbers and growth. Kind of the best estimate, it seems to be about 500 syringe service programs in the US, you know, recognizing that many have limited hours or, you know, may only offer mobile services. So not necessarily in, you know, the same type of places of the ones I visited where they do have kind of robust other services. And, you know, some numbers on this map don't count all SSP locations. Kaiser used data from the North American Syringe Exchange Network. So again, that website will be on the slides. You know, so you can click on that and see a listing, which I believe includes also addresses of the locations in each community. Is this a number anybody has more information about? Just curious that you've heard.
I know New Mexico must have more than 0 to 3 because I actually had been contracted to set up the first syringe programs in New Mexico, and they did it by district.
Okay.
I believe there are 4 health districts, and they really wanted 1 in each district.
Okay. Yeah, I think it probably is an undercount because they're over, you know, I think they were pulling data in 2021 too, you know, so by the time it gets published, but it's a helpful resource and, you know, just because they're, you know, seeing a map there. But the idea being that, you know, given the fact that there may be 500 of these around the country and, you know, not many in rural areas, that thinking about harm reduction and where it happens, that, you know, syringe service programs, you know, are one venue, but certainly not a venue that's accessible to everybody. Morgan, thank you for adding. Kentucky has 82 operating as of August. So that's, I believe Kentucky was the state that wrote into the Kaiser Family Foundation because they had kind of a footnote saying this is an undercount in Kentucky. So, you know, if anybody has an updated resource to share or list, it'd be interesting to see that. And Carol had also mentioned syringe vending machines. So, you know, that's something that's increasingly happening. Also naloxone vending machines in different places. So a way to kind of broaden and take harm reduction kind of strategies to different places. So overdose prevention centers, I have not visited the ones in New York City. My husband, Graham, photographed the 2 locations here for New York Magazine. So I got to see a lot of the photos he brought back and, you know, have met people who are working in there. Just to, how many of you have heard or read about these facilities opening? And I should say they actually opened within existing syringe service programs and harm reduction programs in New York City. Are these, Carol's raised her hand. Danielle, great. Hopefully you can share. I've been to the East Harlem location. Kelly's raised a hand. Ashley, so heard of them. Great. So just to kind of give an overview here, the idea is, and then sometimes they're called safe consumption sites, used to be safe injection facilities, but kind of recognizing them that's not the only way that people consume substances. And then sort of the idea was to shift to overdose prevention centers, which I think, both in tandem with rising overdose deaths being a risk, but then also kind of as a way to broaden the appeal of these, certainly to policymakers and community members, there's sort of been a shift to using overdose prevention center as a name. But basically hygienic facilities where people can use drugs, offer education, equipment, and oversight of drug consumption, intervene if someone overdoses. Important to kind of note that, at least in New York, most often they intervene using oxygen as opposed to naloxone, and kind of find that providing oxygen and support makes kind of using naloxone less necessary. And often they use the injectable naloxone as opposed to Narcan, just to be able to kind of titrate the amount. Provide or connect people with health and social services, including treatment. I noticed in the chat that someone had talked about acupuncture. If I showed a bunch of photos from this, you could see, they do have a room kind of where people can relax or get acupuncture. And that's also open to the community too, not necessarily just people who use substances. And that, again, this service is within a broader organization that also offers other services. And so there are 2 that opened in November 2021 at the Washington Heights Corner Project in New York, and then the New York Harm Reduction Educators in East Harlem. Danielle, did you want to mention?
Yeah, I was going to mention that they are actually the same organization now. They have merged. So, and they're calling themselves On Point NYC. Oh, I see. Actually, you said that. Sorry, I didn't read the slide carefully.
That's okay. Yeah, so it's kind of an umbrella organization. Any thoughts from your visit?
Yeah, they're doing quite a lot of things. So they're also using microdosing, and they have, as you mentioned, they have nurses on site. They have social workers on site. They also have a lot of peers that are engaged there. They have a kind of like, they have support groups. They also have like a PTSD support group that they're running. They have like a donation site so people can drop off clothes and other supplies. They have showers on site. They provide like hygiene kits, towels. It's actually a really nice space. And so on the upper floor, they also have, at least at the East Harlem site, they now have a nap room that has like 10 beds in it that peers will supervise so people can feel safe falling asleep so their stuff doesn't get stolen. And they also have a area that is kind of like a Reiki, sound therapy, acupuncture, and like massage site. So yeah, it's a really nice space, and I'm hoping to see more spaces like that pop up. But there, I mean, obviously has been some community pushback, and we're trying to navigate that. But we partner with them a bit because our sites are in the same location, same catchment area.
I'm going to come back to you because I am curious. I had reached out. So Sam Rivera and Kaylin C are 2 people who kind of are leading this initiative. And, trying to kind of understand a little bit more about how they're working with treatment providers. But I'm going to come back to that if that's something you might be able to share about.
I'll try my best.
So this is, as Danielle kind of previewed, so it is called On Point kind of more broadly. And, I would say did a really great job of kind of working with media and sort of their rollout as part of kind of a public education campaign. And really this, I think, is going to produce a lot of data to see sort of what the impact of opening these services has been. So if you go to the website, this isn't updated necessarily in real time, but kind of as you scroll down, you'll see this picture. And so this is the number of participants served since the launch. So, you know, a little over 2,300. Utilization, so that's the number of visits. So it might be the same people visiting multiple times. So over 55,000. And then intervening in 700 and more than 700 overdoses. So sometimes this gets reported as they saved, you know, 700 lives, which I think public health researchers are careful to kind of describe it as an overdose intervention. You know, no doubt many of those were, you know, lives saved, but that, you know, this is really about kind of intervening when those symptoms are happening. And you know, the Center for Opioid Epidemiology and Policy at NYU Langone is leading an evaluation to assess the impact of these OPCs on both individual and neighborhood outcomes. So, you know, looking at non-fatal overdoses, syringe litter, you know, a number of behaviors. So I think they've really set this up to try to learn from this and hopefully provide information to, you know, other communities about, you know, lessons learned, and kind of, I know they're also kind of meeting with or people in different states that are kind of exploring this as an option. And just kind of as far as that data, some of this has come up in the chat or been shared. You know, I think, you know, this comes from a study, got the link in there, you know, that kind of looked at overdose prevention centers in broadly around the country or around the world. And evidence pretty strongly shows that they reduce overdose deaths and OD-related EMS calls in the neighborhood, reduce public drug injections and syringe litter. I don't know if this has been publicly disclosed, but, you know, the On Point has talked about kind of getting reports from the Parks Department at how much, you know, the syringe litter in the nearby areas has gone down in New York City. They do not increase nearby drug-related crime, which, you know, can be a concern, and, you know, serve participants who are not in contact with other health services. And I think that's something that's really important to highlight, that you really see, you know, those relationships getting built when you spend time there. And, you know, ideally those, you know, increased participants' use of health and social services, including treatment. So, you know, some of those kind of key studies I'm going to talk about next week, but, you know, that area is sort of one that I think, you know, is really important to explore, is sort of how are those connections to care and treatment really broadly, you know, happening. It was pointed out in the chat that there's sort of a light coming in here. I'm not sure I can address that, but bear with me. I'm not used to sunny days here. So these are some links that I recommend if you haven't seen them, you know, kind of a range of media coverage. And then, you know, the second one is a video that On Point put out that really talks about how their services work, you know, and, you know, as I've said, they did a great job, I think, with engagement here. And then here's a report from the Department of Health that kind of talked about lessons learned so far. So I think there'll be more information coming out, but if this is something you're interested in learning about, that those are great resources to kind of get started. Anita writes, I work with On Point almost every day, and I can tell you that harm reduction saves lives. So anything either of you want to share?
It's Anita Kennedy. I'm from Mount Sinai, Beth Israel. As I was saying, I work, my office is not even a block away from On Point, and I work with, I do street outreach in the East Harlem area, and I work with a lot of the peer workers from On Point as well. And we go out into the parks and we provide syringes to people. We provide smoking kits, a lot of Narcan trainings and Narcan kits and fentanyl test strips. And, you know, we're out there early in the morning, sometimes as early as 6 o'clock in the morning, late in the evenings, everything. And what a lot of people like about the harm reduction model is that it's judgment free, and that people are just allowed to do whatever it is that they need to do. They're given the opportunity to have their lives supported. And you know, this has been beneficial to so many people. So I'm very grateful for harm reduction.
Great, thank you for sharing that. So yeah, and I think, you know, as we learn more too, you know, I know Sam has said in interviews, you know, that, you know, a lot of participants do ask about treatment. So, you know, that's something that I think, you know, more will be kind of learned about how that connection to treatment is happening there for people who are interested in it, you know, in addition to all the other services they provide. But, you know, it is, if you see posters around the office, you know, they do talk about that option for people. And I think, you know, that's sort of part of the focus of this workshop is sort of how can those relationships be built and strengthened as well. Deborah asked, how does a grassroots organization get access to the prevention kits? So are you asking there about the naloxone? Or feel free to clarify. Okay, I'm going to show a website that, you know, it can be a resource that lists, you know, places around the country. So called Next Distro, but that should be coming up later on there. Carol has added it too. Let me just write, Carol, maybe you could type in the website there, but it should be showing up here, or it might be coming up in the second session next week. So just to kind of illustrate, you know, I mentioned that Washington Post article talking about, you know, more places legalizing fentanyl test strips, but, you know, this was, you know, the American Rescue Plan included 30 million in grants for harm reduction services. You know, the White House calls that an historic amount that will enhance interventions like syringe service programs through a grant operated by SAMHSA. You know, there's also kind of through the opioid settlement funds, opportunities for additional grants. And, you know, certainly this was sort of recently has been kind of an embrace by the federal government of this approach. And just here's a headline from the Texas Tribune that even in a state like Texas, you know, Governor Abbott said he supported decriminalizing fentanyl test strips. And, you know, if here, I'll add this link to the, oh, this should be a link that's accessible even if you aren't a subscriber to the Washington Post that talks about fentanyl test strip availability. Just type that. You know, so at the same time, you know, the support for some initiatives has limits. So, you know, I thought this was interesting. You know, there was talk about the veto by California Governor Gavin Newsom of, you know, legislation that would have allowed overdose prevention centers to open in California. And, you know, so I pulled up kind of the veto letter from Governor Jerry Brown in the same state from 2018 and Gavin Newsom from August 2022. So, you know, these are sort of language that you hear a lot. This is a little bit kind of small here, but, you know, Jerry Brown writes, fundamentally, I do not believe that enabling illegal drug use in government-sponsored injection centers with no corresponding requirement that the user undergo treatment will reduce drug addiction. And, you know, enabling is kind of a word that comes up a lot. And Gavin Newsom kind of takes a little bit different approach in 2022, saying, you know, the unlimited number of safe injection sites that this bill would authorize could create a world of unintended consequences. It's possible that these sites would help improve the safety and health of our urban areas, but if done without a strong plan, they could work against this purpose. Worsening drug consumption challenges in these areas is not a risk we can take. Now, a lot of people kind of felt that these were kind of tied into political ambitions, certainly in Governor Newsom's case, and whether or not that's a correct reading of the situation. I think that, you know, California, and certainly some communities in California, kind of are experiencing, you know, a lot of challenges in communities like the Tenderloin District in San Francisco, and kind of trying to figure out how to navigate different perspectives and interests about that. This is just kind of an example of some of the media coverage, and you know, there is research sort of linking how the media coverage can then affect, you know, the availability of services in different communities. So on the left is an article from The Economist, and then, you know, a couple more, you know, from local news. It's kind of talking about, you know, in some cases, you know, the one on the top right started out with someone sending a friend of the family to go get syringes through an needle exchange program, and then posting on social media, and then that resulted in a lot of media coverage. And the second one is below is kind of in Salt Lake City, you know, so just kind of trying to capture that, you know, there still can be a lot of tension between people who prioritize different services and intervention and people who either just don't want these services or have concerns about them. So that kind of leads into this questions, you know, what are some concerns or hesitations you've heard about harm reduction?
35 years of training people in harm reduction nationally and internationally. Enabling comes up a lot. Bringing people to drug use who never would have used before. The not in my neighborhood approach, the approach that really just doesn't consider people who use substances as worth rescuing, and just the stigmatization that accompanies that. It's almost like, why are we wasting our time and money with these people?
Right. So you've captured a lot. Any other thoughts on just things you've heard?
Way back when I started, it was also seen by some people in communities of color as an attempted genocide, by facilitating drug use within those communities. So it was also seen as, on a certain level, racist.
And that's, I think, still, you know, comes up in communities. So even with On Point, you know, in neighborhoods that say, well, why are these services always in our neighborhood? Why don't you put them in, you know, the Upper East Side of New York or the West Village of New York? So, you know, that is an objection that sometimes is framed as, you know, we don't, it's not that we're against these services, but we do feel like our community experiences, you know, more of them than other places. Jason adds, much of that not worth the effort sentiment is rooted in hopelessness about addiction, you know, so I know that's something you've written a lot about, and kind of this idea that, you know, that sort of pessimism about the prospects of, you know, people moving along the continuum of care, and that kind of just are doomed to, you know, I think someone once expressed it, you know, to my husband as sort of, you know, death or jail being the outcome. Carol writes, seeing people as disposable. So feel free to keep adding there. I mean, this is kind of just certainly not an exhaustive list here, but, you know, one of the concerns, as Carol mentioned, you know, enables risky drug use or encourages that, makes neighborhoods less safe, you know. So again, these are concerns that somewhat are attached to SSPs, you know, places that have physical locations, or where mobile services are happening. Spends taxpayer money on people who made bad choices, you know, so we often talk about taxpayer money, and I think you got in the chat and Carol's captured this idea of these people made bad choices. So, this isn't worth taxpayer money. Offers medications that substitute one addiction for another. So, we'll be talking about kind of medications as one form of harm reduction and treatment, and kind of thinking about this idea, of replacing one addiction for another, has sort of historically been something that's mentioned. And opposes abstinence and recovery. Sometimes there can be this perception, even among people who, are longtime harm reductionists, that might also feel positive about abstinence and recovery or embrace that. And, a sense that harm reduction is opposed to abstinence and recovery, even though that's mentioned in many places, as part of principles, that it's not. That can be a perception that people either feel or experience. Only reduces some harms related to substance use disorders. So, we started talking about that. And I think, as you get to the bottom of this list, these are concerns that kind of maybe come under the category of not enough, that, harm reduction is a starting point, but, as the bottom bullet point says, meets people where they're at, then leaves them there. So I think now the field is kind of starting to wrestle with, this idea of, how can people who utilize harm reduction services be linked up to other services and care, or how can that kind of menu of services that's offered, be expanded and made more accessible to people. Darlene writes, waste of resources. So, money is always limited, so, and policymakers make choices about how it's spent. So, that idea of, sometimes you hear, well, why should we provide this? I have to buy my needles, I'm a diabetic, or syringes, I'm a diabetic, or, why is my medication not free? So these are objections that often come up. Any others you'd add, or any thoughts on this? So at the same time, if you think about bridging harm reduction and treatment, the next question is kind of, moving into treatment, which we're going to talk about, much more kind of in terms of making these connections next week. What are some concerns or hesitations you've heard about treatment in your community, in your work, in your life?
It's a revolving door. People are using it more to lower their tolerance or get away from somebody they owe money to, or 3 hots and a cot.
So you're thinking about medication in that context there?
Just everything around treatment, people going into treatment. Many people leave treatment because of the rigidity. Some programs, not so much now, but when I started working in the field, functioned on the belief that you had to tear people down before you could rebuild them when they were coming in already completely torn down. People are often mandated into it. It is certainly not gender responsive, particularly to women with children. It is often not LGBTQ plus friendly. So I think that huge kind of abyss that has existed historically between harm reduction and treatment has not really changed that much. I would say to a certain degree, it may have gone in the opposite direction, because at the beginning of the HIV crisis, there was more flexibility, particularly in methadone programs, not to kick people out when they had a positive tox, and particularly because of the risk associated with HIV. HIV now is very different than it was 35 years ago. So it's not being seen in the same crisis light.
Great. So that's a pretty comprehensive list too. I think that, also in terms of just if you look at the media coverage, so a lot of it tends to focus on, as media sometimes does, looking for kind of bad actors, I would say in quotes, so, for-profit rehabs, I think it's important to point out too that, for much of my life, certainly, addiction treatment was not covered by insurance. So, the idea that, there existed these two systems of care, we'll be talking about more, but, that the subset of the industry that gets focused on is the industry, very high priced, often treatment centers that, are operating for-profit models, reflecting our healthcare system as well. Deborah has a hand.
Yes, thank you. Yes, our organization, like many other that I collaborate with, we are a recovery community organization. And what I've experienced in the past 3 years, that if you're not a, certified organization, it's hard to get access to good health care for our clients. It's hard. We haven't even been able to get, certified to bill Medicaid, and all of our services have been free for the past 3 years. And because of that, and us not being certified, the people who really need the services the most are not getting access because they may not have Medicaid or Medicare. And I have clients who come into my office every week who are struggling with opioid abuse, and they're not able to even get to the methadone clinics. They don't even have bus tickets. And I've called social services to try and get bus tickets for our clients, so that, because we have people that really want to get off of these drugs. I mean, some of our seniors in Fort Smith are addicted to opioids and heroin, and the heroin and everything. The heroin is big in Fort Smith. And I have people waiting at my door when I get to work in the morning. Miss Harris, I'm trying to get to the methadone clinic, and they're really trying, and it's heartbreaking to me that we can't provide the needed access to proper medical services. So what are we going to do about helping the people in the communities who don't know about gap insurance? You may have to go to a CSB, one of the community service boards, before you can even find out about GAP, the government access program. So I think that's a huge problem. Not having access to proper health care, and organizations like myself, the grassroots organizations who are on the ground, who are out there finding out about the people who are struggling with addictions and living with suicidal ideations because they don't know how to stop getting high. It's a real issue that you go into treatment. And I know from lived experience, because I am a registered certified peer recovery specialist in the state of Virginia. And I know also well how the system is like it caters more to the larger organizations that because they have the certifications or whatever, they receive all of the funding. Like even on this call, I had to ask the question, how do we, as a small grassroots organization, get access to preventive medications and stuff, like Nox and Suboxone and all of these things that will help to maybe reduce the cravings. Because what I do, I focus on long-term recovery. It's not helping the insurance companies. It's not helping the emergency rooms. It's not helping anybody for our clients to constantly run in and out of treatment, say for what, like I heard the young lady say a moment ago, three hots in a cot or whatever. That's not helping our communities. It's not helping the insurance companies, not helping the emergency rooms or anybody if we're not, providing support for the recovery communities. So who can address that?
And you said you're in Virginia, Portsmouth, Virginia?
Well, our office is in Portsmouth. We started out in Virginia Beach for 2 years. We've been in Portsmouth operating for over a year. I live in Chesapeake myself, but I serve all of the 7 cities. We have clients that come from Newport News and all around. We do our best, but we do the best. We have to turn so many people around, but we can't do what our mission is, long-term recovery. And that's very important.
Mm-hmm.
The cycle is going to continue unless these real needs are addressed. People go in treatment for 30 days, but the real deal is learning how to live sober out in the real world. You're in a secure environment in treatment, you're getting medication, you're getting what you need, but then when you come out, what then? So, and maybe that's for another meeting, I'm sorry, but
no,
I just never hear of things like this being addressed.
Yeah, so you've hit on a lot of really relevant points too, and that's partly why I was asking. I mean, I think living in a city like New York City, a lot of the kind of policy is grounded in cities, and there's pretty belated recognition of challenges in rural communities with treatment. And in New York City, you can get a subway pass and get on. Maybe someone could, you want to just mute, and then Jasmine, I'm going to get to you there.
Well, I actually had a response to her because I sit on the Behavioral Health Advisory Board in the city of Portsmouth, and we have tons of resources and programs, and many of them are underused. So I'm sorry, I'm not familiar with the organization, the community-based organization that you're a part of, but I'm wondering what connections you have with the behavioral health in all of the cities, because I can tell you right now, there are literally hundreds of thousands of dollars and in some cases, millions of dollars available in our funding and our budget for programming. And the thing is, people are not coming. We have 4 homes in Virginia right now that are empty, that are for people who are transitioning, getting out or transitioning. And the qualifications are that they have to have been in our program and in drug abuse. We literally have 1 person out in 4 homes that we have available, and each home has 3 to 5 bedrooms in it. So there are tons of resources and tons of community-based programs and tons of money in the city for these things. So I'm wondering who you're connected to, and if I can assist you with some of those things.
Okay, yes, I'm Deborah Harris, and I'm the founder, president, visionary, and CEO of Your Wellness, Inc. We are a suicide prevention / mental health resource organization, and we're currently located in the state of Virginia. I will put our website on the line in the chat if you'd like to find out more about us. You can email me at yourwellnessinc@gmail.com, or you can just call me and I can put all of my information. I also am the owner of Just Peers LLC. It's still under development. It's a peer-run organization, and we've been struggling to get those services off the ground for 2 years, but I would love to connect with you. Fortunately, I just got approved for a partnership with the Virginia Health Department, and I will be meeting with them in the upcoming weeks to discuss our behavioral health program. And yes, I wasn't going to say anything on this call, but I am glad I did, and I would love to connect with you if you can put your information in the chat.
All right, thank you, Deborah. And the other thing that you shared, I'm going to just put another link in the chat. If a source, what you brought up too is sometimes the money, there's a lot of money that's out there, and going to be more money with opioid settlement funds from the different laws. Then, this opioid settlement tracker site, this is slightly off topic, but is a great resource. you know, that has listings by state too. So, you know, some states, as they're dispersing this money, have an open application process for organizations, but, you know, the pipeline of kind of federal and state money is one bucket, and then there's money that's going to be coming from these settlements over the next 18 years. So I'd really encourage you in your states to kind of familiarize yourself with what's happening in your state and what processes are open to different organizations to apply for some of this money. Because, you know, Deborah, the point you brought up, sometimes people aren't aware of it, you know, just as evidenced by, you know, the two organizations being in the same state here. Jasmine, you have a hand up. Did you want to add something? Or is that from before?
Oh, my apologies. Actually, I did have my hand up for something prior to what she was stating. And I was, there was someone who was speaking and they were talking about their clients not having Medicaid and Medicare. And I guess I was wondering why not, because in a lot of circumstances based on income alone and community-based services, being homeless, those are things that they typically approve. So the person who was speaking in reference to that, and also the person who just spoke a second ago, I would highly recommend that you look at your cities and your states and the resources that are available, because a lot of times community-based organizations, they start these grassroots efforts and they forget that some things have to go through the city or the state, or there are restrictions, but they're really, it just goes back to what I was saying before. There really are so many resources that are available and so many benefits, but if no one knows how to apply, when to apply, what they need to do in order to get, you know, someone, I know the woman who was just speaking before, she just mentioned that other organizations are getting the funding because they have certifications. Well, sometimes you need to be a government-based entity in order to get those certifications. The certifications are unavailable to private entities, but then there are some that are. So I would just highly encourage anyone in this industry to check with your city, your state, your county, and their behavioral health department and their social services departments to see what the rules are, because a lot of times as we start talking, and there are resources, it's so much out there. There are so many resources, and I don't know why someone who's homeless or doesn't have income wouldn't have Medicaid.
Mm-hmm.
They would apply. They could apply for Medicaid. If you don't have any income, you're gonna be approved for Medicaid. It's really that simple.
Thank you for that. I am aware that, because I'm a researcher as well, and I'm aware that of all of the funds available. We even had I organized and hosted an event at the Inky Hub where one of my offices is. We had the secretary from the governor's office. And our Governor Youngkin, you know, he says he's very, and I believe it, that he's very passionate about behavior health. So we had Secretary Little I invited him to come out, and he showed up, and I presented our portion of our behavior health program. And I was told that this office would contact me. This has been over a month ago. I haven't heard back. Nobody has responded. But I guess I'm not persistent enough, and I'm just trusting God to hear back from them. But I've applied for many grants. I'm not a grant writer, but because I can't afford to hire anyone, I do a lot of work myself. I've applied with SAMHSA for several grants. I've even hired one of their evaluators, paid the money, and these are 300-page grants, some of them. I've done the work, and even the B Corps grant that a lot of the certified organizations received millions of dollars. And Virginia was not even chosen to receive that grant. So, you know, I'm aware of a lot of the funding. I was not aware of the funding and right here where I live, what the young lady just mentioned.
I'm gonna pause. I'm sorry to interrupt. I'm gonna pause because we just have a few minutes left here. So there were a couple of things I wanted to wrap up, but Iman had a hand up. Do you wanna add something?
I did want to add something, but I think it would just belabor this point, so it's fine to just move on.
Are you sure? Do you want to
Yeah.
post it in the chat, or we'll make a note and we'll come back to it on Tuesday?
Okay, thank you.
Great. So I think, this is a discussion that, everybody has a lot of frustrations about treatment access. And when I say treatment, I'm kind of thinking, we'll talk about this next week, just really broadly about care and services. I have a very expansive view of treatment, but just to kind of summarize some of the things that have been discussed, part of the challenge in kind of linking up this harm reduction approach and treatment, or just people who have needs and treatment/services, is kind of this, pessimism sometimes that treatment doesn't work because they've heard about that or had personal experience with programs, that it can be very difficult to evaluate success. I often point out that if you look at a pie, treatment is a slice of the pie that helps people, and there's a whole other part of that circle or sphere. So you can have the best treatment in the world, but if you have a criminal record, can't get housing, can't get a job, don't have access to transportation, it's really hard to kind of keep rebuilding your life. Too punitive, discharging people for minor infractions or a positive drug test, historically has been an issue, certainly not available when needed, whether that's waiting lists or that there's a two-tiered system based on income and insurance coverage. And now that insurance is required to cover it, a lot of the frustrations that people have in actually accessing that. And, I know that there's more effort to make sure that the Parity Act that requires insurers to provide coverage for these services, for behavioral and healthcare to the same degree as physical healthcare, there's still a lot of challenges getting that implemented. People have reservations about medications for opioid use disorder. At the same time, there are also restrictions, that are slowly getting lifted, particularly post-pandemic, that have limited access to those medications. Another concern cited is, too focused on abstinence as a universal goal. Next week, we're going to kind of talk about ways to approach that kind of encompass kind of a broader set of goals, and then doesn't meet individual needs, especially for certain populations. So, that's been mentioned, women, people of color, LGBTQ+, a lot of people find that the services that have historically existed, don't necessarily meet their needs. So just to wrap up, I wanted to show, many of you might be familiar with this national survey on drug use and health. This is the most recent data that came out, and these slides are pretty detailed. I was kind of trying to capture what they show, but this was from 2021, and found that 16.5% of the population 12 and older had a substance use disorder. Now, some caveats are these surveys, this isn't an actual diagnosis. There were some challenges kind of conducting these surveys during the pandemic. But, that's a pretty high number, to come up with. And I know Jason on this has written about that. Maybe he would add in the chat or next week, his assessment of that survey and whether we're overcounting people with substance use disorders. But, relevant as we kind of look at the need for substance use treatment and whether that need is being met. So this was pretty striking from this survey that, the high percentage in the population, 18 to 25 needing substance use treatment, 25% versus, other age groups, really stood out in this recent data set. And, as an average, I'm sure many of you have heard, 10% of people received any substance use treatment in the past year among those who had a substance use disorder, so that, we often talk about this kind of treatment gap and, the fact that people who need services are not getting services. Now, bearing in mind that, many people recover without treatment, formal treatment or specialized treatment, but that there's kind of no doubt that there are also many, many people who would like treatment who aren't receiving it. At the same time, when we think about bridging harm reduction and treatment, this statistic always kind of jumps out at me, you know, perceived need for substance use treatment among people 12 or older with a past year drug or alcohol use disorder. You know, 97% felt they didn't need treatment. I'm sure many of you kind of working in this area or who've experienced this in your own lives, you know, that's a huge number, or that's a huge percentage and a huge barrier to kind of overcome, is, you know, the fact that people feel they don't need treatment or they don't want treatment, and kind of how we can look at that, you know, statistic and that resistance, and kind of, you know, make treatment be something that people want and recognize a need for, you know, through some of the things to make it more accessible, to make it more appealing, to make it fit their needs better. So, you know, landing kind of pretty close to 10:30 here, I'm sorry, 11:30. But, you know, next week, we're going to talk kind of more about some case studies and sort of philosophically how we can, you know, bridge this harm reduction to treatment kind of continuum. And, you know, I'll be sharing some examples of places where that is happening, and really, you know, welcome any feedback. Or, you know, the next session in this workshop will be the 15th from 2 to 3:30. And the slides will all come, you know, together after the second session. But, you know, just if I'm going to just add my name to the chat here, or my email address, you know, feel free to share any thoughts or topics. You know, I'll see what I can incorporate for next week. And I hope that wherever you're joining from, you're having this great weather that we're having today, which is also a little alarming on the climate change front. But have a great weekend, and I really appreciate your participation and thoughts on this topic.
Thank you.
Thank you.